Hello, I am every woman. It's so nice to see everybody. Welcome to our National Volunteer Call. We are so glad to be back in community with you, and we are thrilled to be joined by Dr. Jallicia Jolly and María Antonieta Alcalde Castro to celebrate National Minority Health Month. Jallicia is a writer, researcher, doula, and incoming assistant professor and postdoctoral fellow at Amherst College. And Maria is the director of Ipas Central America and Mexico. My name is Giovanna, also every woman, whichever one you prefer. I go by she, her, hers pronouns, and I am the Population Connection Action Fund Grassroots Advocacy and Outreach Fellow. Before we get started, I'd like to get to know you all a little bit better. So in the chat, I'd like for you to drop your name, your pronouns, where you're joining us from today, and what you are most looking forward to now that warm weather is upon us. We have made it. I'll give you a few seconds to type that out. Again, that's pronouns, name, where you're joining us from, and what you are excited about now that spring has sprung. Okay, 3, 2, 1, send. Road trips. Yes, KD. Picnics, barbecues. Oof, I'm loving all of these things. You're giving me all of the ideas and yeah, bringing all kinds of excitement into the room. Before we jump into the conversation, I want to cover just a few housekeeping items. Please make sure you keep yourself muted while the speakers are talking to avoid any audio interference. And we've taken steps to make sure that this is a safe place, but there's always a chance that we could have online trolls who interfere with the event. If that happens, my colleague Lindsay will share this image on her screen until the person has been removed from the meeting. So before we get started with our conversation, I'm going to kick it to Lauren to talk a little bit more about us.
Hi, everyone. My name is Lauren Salmieri. I am the advocacy specialist at Population Connection Action Fund. My pronouns are she, her, and I put it in the chat, but I'm really excited for some picnics. I live near the National Mall, and it's nice to just go sit there and enjoy the views. So I just want to give a little bit of background and context to who we are. So Fight for Her, or Fight for Health, Empowerment, and Rights, is a campaign that was started by Population Connection Action Fund to mobilize action against attempts to roll back access to safe, affordable, and comprehensive reproductive health care around the world. And we are the only grassroots group that's doing activism on this on the ground. And we are working to repeal devastating policies like the Global Gag Rule and the Helms Amendment. And we're so glad to be doing this work virtually, and we're really looking forward to getting back to being in person as well. Next slide, please. Thank you. So just a little bit about what we've accomplished so far since this campaign was launched. We've engaged 54,000 constituents since 2017, which is just an amazing number of people who are educated and activated around this issue of defending reproductive rights for folks around the world and preventing policies like the Global Gag Rule from being in effect. Next, please. Yeah, so we passed the we repealed the Global Gag Rule with President Biden, and now we need to pass the Global Her Act so that no future president can reinstate it. So we're going to get into a little bit of that later this evening. And we're so grateful to have everyone in this movement with us, and we're happy that everyone has taken the time out of their Wednesday evening to join us here, and the gift says it all. So thank you so much. I'll kick it back to Giovanna.
Thank you, Lauren. Okay, let's get started. So I will have both speakers briefly introduce themselves, their work, and their background, and then we'll just dive right into the discussion. Maria, I'll have you start.
Sure. I'm María Antonieta Alcalde Castro. I'm a Mexican feminist. I started working on sexual and reproductive health and rights and reproductive justice when I was a teenager, and I participated in a lot of national processes, but also international processes, as the Conference for Population and Development and the +5, +10 for 15 and 20s, and the conference on women's rights, the World Conference on Women's Rights. And I was also part of several UN negotiations at the UN. So when I retired from being a youth activist, then I formally started working on this issue. I worked for International Planned Parenthood Federation for 14 years. I was the director of advocacy of IPPF Western Hemisphere region and the director of the UN liaison office for the IPPF. And then I moved back to Mexico. I was in New York doing work with IPPF, and then I moved back to Mexico to be the director of Ipas for Central America and Mexico. Ipas is an organization that works in Latin America, Africa, Asia, advocating for women's rights, specifically for safe and legal abortion. And that's who I am.
Wonderful. Thank you so much for joining us. Jallicia, would you introduce yourself, please?
Yes. Hello, everyone. My name is Jallicia Jolly, and I am a doula and currently an assistant professor in American Studies and Black Studies at Amherst College. I am an educator and reproductive justice practitioner, and much of my work focuses on Black women's health and activism, reproductive justice, and health inequities in the United States and in the Caribbean. And I would say the sort of broad section of my work is really focused on anti-racist organizing that it is really advancing equity. I'm also very much interested in improving maternal health and in elevating HIV/AIDS care and mobilization among women in the African diaspora. And I'm specifically invested in human rights lens and a reproductive justice framework. And I think a lot of my time is spent sort of applying work, research to sort of interventions and community-based strategies to really invest in the capacity of people and everyday people and in communities, because I remain inspired by work that happens at the grassroots level to effect structural change on a wider scale. And that's how I started. I started as an HIV organizer in Brooklyn at the age of 15, and I never forgot my roots because that's what drives me and sets my soul on fire. So it's great to be in good community.
Thank you so much. We are thrilled to have you both here. And with that, I'm going to go ahead and present the first question. So why is it necessary to highlight the reproductive health inequities faced by Black and Brown communities specifically, and who makes up the minority populations in the countries that you serve and research? Jallicia, if you'd like to go first.
Yeah, absolutely. So I want to say I appreciate the space too to have this conversation about the barriers created by U.S. policies on access to reproductive health care at home and abroad. I think making these connections are crucial. So one of the reasons that I'll say it's important to sort of highlight the reproductive health inequities faced by Black and Brown communities is because there are grave injustices that really have been heightening the violation of human rights for these populations. And we know that these communities continue to experience various forms of reproductive violence, abuse, coercion, poor access to quality care, disproportionate rates of maternal morbidity and mortality, just to name a few. And I'm a firm believer that how you treat the most vulnerable among you has direct implications on the entire population level. And so how we address these reproductive health inequities that we face will have far-reaching impacts on the services we provide, on the care we give, on the policies we make, and on the advocacy strategies we use.
Thank you. And I mean, just to add of what Jallicia was saying, most of my work is now in Latin America and the Caribbean. And it's interesting when we talk about minorities, because in many cases in this especially in these countries, like well, women are not minority, are more than half the population, but then indigenous population is not necessarily the minority. Like if you see places like Guatemala, Honduras, the vast majority of the population is indigenous. And if you go to the Caribbean, the vast majority of the population is African descendant. So many times when we think about minorities, we are not talking necessarily about the less people in that country, but actually I think that we're talking about vulnerable populations, and it is interesting to analyze what makes this population vulnerable. And many times when we think about vulnerable population, it looks like they are just vulnerable because and it's not, it's people that are facing vulnerable conditions because the societies we live in are structured in a way that makes them vulnerable. And I think that it is very important, like the most of the population that we work with, of course, women, but there's a lot of intersectionalities. And I think it is very important that we approach this work with the lens of intersectionality, because many times, like just being a woman, or even maybe many times we think that wealthy women or white women do not face a sexual and reproductive health issues, or we think that by addressing just the racial aspect of an issue, then we solve a problem. And it is very important that we look at this population, for example, the populations that we work with in Central America that are indigenous, but on top of that, they live in rural settings, so they are far away from the cities where most of the services are. Many of them are migrants or are families of people who have migrated. So, for example, we work in a lot of settings where you have very few men in the communities, because like several of men had migrating, but most of the community depend on the money that they send or they don't send. And so there is some different things that change in the community and the roles that women had to take on that. So you have women who are indigenous, but they are also living in rural settings, facing migration, and then on top of that, they are young, for example. So they are being young in certain communities give you more or less power. So it is very important, and that when we work on sexual and reproductive health issues, and when we think about the type of policies that we need, we look at not only minorities, because many times the most vulnerable people are not necessarily the minorities, but the people who are living in vulnerable conditions, and then what makes them vulnerable, and then not put them in silos, but actually look as the cross intersectionalities that made them vulnerable. And those are kind of the lens that we are using to think about. It's not just policies for African descendant, policies for indigenous, policies for young people, policies for migrants, but how can we link all these and wave so we can actually create programs and policies and approaches that takes into consideration this waving of intersectionalities that makes people vulnerable. And so those are the people that we work with. They have all these conditions that makes them many times vulnerable.
Thank you for emphasizing the many things that can make someone part of a vulnerable population or a minority population. Okay, so the next question is, what is the state of reproductive healthcare access for Indigenous and Afro-descendant populations who are already economically, linguistically, and racially disenfranchised in Latin America and the Caribbean?
Well,
Julie.
Sorry, go ahead.
No, go.
Okay. Yeah, no, I really appreciated you sort of laying out the tiers almost in the different ways people experience marginalization. And I think that I think characterizes the state of reproductive health care access for Indigenous and Afro-descendant populations in our context. I think I'll speak in particular for Afro-descendant populations in the Caribbean. You know, one of the things that I've, in my decade of experience working there and researching there and sort of just visiting and observing and navigating space there, is that I've noticed there's an unmet need, and research has also shown this, but there's definitely an unmet need for sexual and reproductive health care, right? And these include services that take that together ensure people can decide whether and when to have a children, whether they can experience safe pregnancy and delivery, if they can experience that safety, if they can have healthy newborns and have a safe and satisfying sexual life. So like this question of bodily autonomy is definitely an unmet need. And I think class, gender, and structural racism operate in powerful ways that shape access to care and services, as well as who lives and who dies. And so, for example, birthing Black Caribbean women in general have fewer than, sort of 4 antenatal visits during a pregnancy, do not receive the care they need following sort of major obstetric complications. They have newborns who do not receive needed care for complications after birth. And they also have abortions in unsafe conditions and die at disproportionate rates from causes related to pregnancy and birth, right? So we have the perfect storm, so to speak, for a context that undermines the reproductive futures and lives of Black Caribbean women. And I also want to point to a broader context, right? Because I think it can, one reason I appreciate this conversation because it's looking at policies, and I think it moves it from the sort of individualized focus, which can happen often in public health approaches when they sort of individualize risk to individuals or to specific risk populations or groups without looking at the wider context of structures, right, which shapes policies, which shapes institutional practices. So for example, in the context of the Black Caribbean, structural adjustment programs imposed by the International Monetary Fund, the IMF, has long advised governments in the Global South to reduce investments geared towards enhancing the social and psychological welfare of its citizens. What happens when you do that? In order to service a growing debt, what happens is that countries like Jamaica and Haiti saw cuts in funding for education and healthcare, and this accompanied a shift in the responsibility and cost of social issues to individual households, right, and communities. And that's where you also saw a lot of local nonprofits, organizations stepping up to sort of take control, fill in where the sort of state and government services did not exist, right? And so we see this disproportionately and negatively affected marginalized communities and further and created more inequalities. And I think this has caused many countries in the Caribbean, as I mentioned, such as Jamaica and Haiti, to become dependent on external aid for reproductive services and HIV care, for example. At the same time, these countries have become part of a global network of low and middle income countries that comprise a growing share of sort of maternal morbidity and mortality, global HIV/AIDS burden, et cetera. And so the dependency for aid for things like reproductive health care, access and services occurs alongside the sort of disproportionate rates of these inequities in these countries. And it doesn't help that the public health infrastructure doesn't sort of have the necessary support in order to support communities in this context, which is where local communities and organizing and advocacy comes in.
Yeah, I couldn't agree more. And I think that in Latin America, I think reproductive health also show us these disparities. I mean, like you can take some of the reproductive health indicators, and then like if you take maternal mortality, for example, you can see that the countries with the highest maternal mortality in the region are the ones that has the most indigenous population. Like for example, in the case of Latin America is Guatemala and Bolivia, that are like kind of leading the region on maternal mortality with around 300 deaths for every 100,000 born alive. Like this is the indicator. But like you can see that the countries with the most population, but you could say, well, this is a generality. Like, so if you go even deeper in the countries using maternal mortality, you can see that, for example, in a country like Peru, in cities like Lima, you have maternal mortality of 52 per 100,000. And in kind of regions where like you have the most indigenous population, that it's 7 times higher than in the cities and in like when you have more mixed or white population. So you can see these disparities also, for example, on met need of modern contraceptions. Are the countries with the most indigenous populations that they have the higher, like in the case of Guatemala, it's 20%, like 20% of women who want to use a contraceptive and prevent a pregnancy, they don't have access. They don't have a mean to have access. And in Latin America, I mean, like I'm always like when I there is like one element, like in terms of sexual and reproductive health and rights in Latin America, that for me is always shocking, that in terms of teenage pregnancy, the highest rate of teenage pregnancies is in sub-Saharan Africa. And after sub-Saharan Africa, it's Latin America. And it's kind of shocking because you said, well, Latin America, most of the countries of Latin America are middle income or higher income. All the countries in Latin America have a system, health system that it makes kind of suitable or like aiming at universal health coverage. That means that the government provides services to the population. So you would say, well, if the government provides services, those are like kind of income shouldn't be an issue because those are for free or pay with taxes. But like a big part of that high like I mean, if you go to indigenous populations or migrant, it's the rate is really high, and are those populations that are mostly driving a big part of the high teenage pregnancy rate. And Nancy was asking a question in the chat in terms of what are the similarities in the US, and in this case, in my case, in Latin America. And I think teenage pregnancy could be one similarity. Like the US have a very high teenage pregnancy rate that is also driven by minority populations, like by the Latino population, by the African descendant population. So and you can see very like strong linkages in terms of the lack of access to contraceptives. And like you could say, come on, lack of access to contraceptives, there's a lot of information about contraceptives. You go to the pharmacy and buy a condom, but then you have to buy the condom. You have to have the agency to go to the pharmacy and buy the condom. And then you have to have the money to buy the condom. So this idea of like anyone can do it without looking at the social barrier and the economic barriers that we are facing. And I do feel that teenage pregnancy, it's a good indicator of where we are, because as I said, like you could have the kind of the social, like from the top, you can see and say, oh, we have the conditions, we have the economic conditions, we have the social conditions, but it's in the specific of the populations. And the other element that is important when it comes to teenage pregnancy, it's cultural elements. In many of the cultures, becoming a mother gives you status in your community, gives you, I mean, I sometimes I feel that it's a little bit sad, but it's true that in some cases, this is the kind of like the best future that a women can, like a teenagers can aim to. And I said that it's a little bit sad, not because I have anything against motherhood. I'm a mother myself, I have 2 kids, but I think it's a little bit sad that a 15-year-old, that the best she can dream of is becoming a mother, because that's going to give her status. And that's the other element when we talk about reproductive health. It's not only about having access to services and supply, but actually providing and making available to women and girls better futures. So it's not just a matter of providing services, but actually giving girls and teenagers the possibility to dream beyond motherhood. And that, without taking into that, the other big element that is driving teenage pregnancy, of course, is sexual violence. And in many communities, it's not only about, I mean, a big part of the sexual violence is perpetrated by the family. But you have communities where you have a lot of people living in one's household, like different social elements. You don't have street lights at the street. So there are different elements that are driving this, that are related. Some of them are related with sexual reproductive health, but some of others are related with other elements, economic and social elements of the communities that we're talking about.
And what changes can be made to address some of the systemic problems that bar these communities from accessing the reproductive health care that they need, in line with the social aspects and the policies that are in place?
Yeah, thank you for asking that question, because I think it's really important to diagnose and name the problem, and it's also important bridge that to sort of thinking about what this can look like in action, to make that concrete change. So first I want to say that as we think about sort of the changes to address these systemic problems, I want to point out the word systemic, right? Like these are tied to policies, to laws, to institutional practices, to the way people think about people's bodies and racialized ways and class ways, and gender discrimination, right? Gender discriminatory ways, to the way people, so it's deep rooted and it's really intersecting. So thank you for mentioning that, Maria, because I think that when you have intersecting forms of domination like that, you will need intersecting and multi-dimensional strategies to affirm people's reproductive autonomy, well-being, and dignity, and bodily integrity. And so, for example, one of the things I think about is really naming and challenging the ideology that shapes a lot the way we think about reproductive health care and the system, right? So for example, not every reproductive body is valued in the same way. Some people's childbearing is viewed as a wonderful thing, and you know, there are government investments in expanding fertility for certain populations. At the same time, there are certain other populations that are viewed as their childbearing is viewed as a source of moral illness, of social degradation, as the reason for social problems, right? And so they're devalued. So some women are deemed unworthy of protection and basic human rights to give birth, to access care, to access basic resources to sustain their lives and their families because of this ideology. And we know this ideology shapes policies in the U.S. and across the Caribbean, Latin America, and throughout the world. And we know, and just I'm just going to bring up a U.S. example because I know it seems like this is the audience that is here. And for example, I believe North Carolina and Black pregnant patients, right, they would have their urine screened without their consent and tested, right, for illegal substances. And depending on the outcomes, they would be, the hospital staff would coordinate with police to turn over the patient after giving birth to be arrested and charged, right? And so when you think about that ideology also shaping, I can see how that sort of unfolds in other contexts, right? For example, in this group of Caribbean women that I work with who are HIV positive, young women of reproductive age, childbearing age, they sometimes talk about it, how when they access services and they're HIV positive and pregnant, right? Hospital staff, nursing staff, doctors, a whole host of care providers often look at them and ask them, why are you giving birth? Why are you having children? And many times, sometimes often acts as well, basically find coercive ways to sterilize them, right? Or to bring the question up as they're thinking about being, as they're thinking about that moment when they're meeting their child or they're preparing to enter labor, right? At the most vulnerable moments of their lives. And so when I think about what changes that need to be made to address these systemic problems and how pervasive they are, you know, I always turn to communities because that was my first exposure and I see the power of that. And so communities of care structures, right, that do political advocacy to gain access to basic resources, to fund programs and initiatives that raise awareness, that advocate, that build capacity of local people. Social services need to be coordinating with these organizations and community groups that are doing this work, right? And finding ways to make marginalized people get a political voice in the arena of decision making, where policies are developed, where budget agendas are being made, where interventions are being created without centering the people who are on the receiving end of that care, but also who are definitely the people who are targeted by much of this violence, right? And so I think in general, one of the changes that I'm offering here is like this intentional and active participation of those folks Black and brown birthers into this, into the global conversation, into the national response, into the sort of local regional strategies around reproductive health care. And I think importantly, one of the ways that I've seen this being done is by local organization, for example, Sister Love in Atlanta, which is an HIV organization for Black women, and also an HIV/AIDS organization called E for Life in Jamaica. Both organizations working in these different spaces, but using a sort of holistic care model that is emphasizing service delivery, but also integrating that with political advocacy, understanding that the core issues that people are dealing with depend on what they're prioritizing, what resources, and that determines what resources they will want to have access to, right? And we need to sort of meet them there, right? And so I think part of meeting them there and part of centering those voices also requires that we understand the overlapping vulnerabilities that Black and Brown people in these spaces face, right? Such as food and housing insecurity, economic and deep emotional, the need for economic support, the need for emotional and psychosocial support, and different things like that. So I think prioritizing those needs while thinking about integrating service delivery with also advocacy as you're building the capacity of people to organize on behalf of themselves, but also to disrupt the spaces that exclude them from the budgets, of the resources, from the services needed to survive and live a life of dignity.
I think this point is fundamental, and sometimes I like we forget on the importance of including the populations that we are serving and putting them really at the centers. Like, having worked for many years in international organizations and having worked with like a lot of governments, many times there is a genuine interest of serving specific populations, but there is also this idea of we know better, like in terms of like, because we have done research with these populations, or because what it's important, but bringing those specific populations to the table and to ensure that like that we all include them in the work that we do. That like, if you're working with, in our case, for example, we have a large program with migrants, and one of the things that we did first is like approach the migrants communities, like many, like we work basically with migrants coming from Honduras, El Salvador, and Guatemala, and trying to reach the US and ensure that like many women face sexual violence in that process. So ensuring that they had information about that, they have access to contraception, to emergency contraception. And in Mexico, abortion is legal when the pregnancy it's the result of rape. Like for everyone, including for migrants. So and it's free, so the government provides the services. So like they have that this information, but having approaches that help us like put in the center of our intervention the people that we're trying to serve, I think it's fundamental, as Jallicia was also pointing, in terms of bringing the voices of those populations. And for me, I mean, there are many things that we can do. I mean, just talking about this, having these conversations is important. Challenge ourselves. Like, sadly, we live in a system that in education, in movies, in like we have sometimes like structures that kind of like without even noticing, saying like, as Jallicia was saying, like, oh, ensure that the screening was not an evil person that was like, oh, let's screen these women just to see if they have drugs. It was done maybe with good intentions. We want to save these kids, these babies, from like their like mothers who are using drugs, but like they reinforce these stereotypes and these visions that we have. And it is important that we challenge ourselves, that we ensure that we don't have, and we are not working from those approaches, and that we check ourselves and double check what we're doing in our discourse. Because many times, like when we're talking about many times with, and I see it, I was a youth activist for a long time, and one thing that I criticize from youth policies is like many times with a veil of protection or with a veil of education, what you are trying is to control. So we cannot give them this information. You cannot give them these tools because they won't know what to do. So like, I think that one thing that we can do is to challenge ourselves all the time and see which frameworks are we working from. Another element that I think it is important, and for me, I think it makes a big change. And as I said at the beginning, I big part of my career has been on supporting and using international mechanisms to advance the agenda. And in 1994, like at the UN, there was like this big conference, the International Conference on Population and Development. And the ICPD, the International Conference on Population and Development, or CAIRO, as is well known because it was held in Cairo, was very important because it brought to the international community the concept of reproductive rights. And I think that's very important, and it changed the paradigm, the vision of population from a population control approach to an approach that put it in the center, the rights of people to decide how many children to have and when to have it. And that sounds like old history, but now we are facing some voices talking again about population control and talking, I mean, like, and climate change and environment has become very relevant. And I do see an intersection between population and climate change. But there are like some voices saying like, we need to control the population, we need less people, rather to go into consumption and pollution. Like, so it is very important that we maintain the concept of reproductive health, reproductive rights, reproductive justice. In Latin America, there were like several examples in the 80s where indigenous women were forced sterilized with the idea of the public good. We need these people to stop having children because we're going to be too many people in this planet, because they can, like, the country cannot grow economically if we have to take care of all these people. And in Peru, for example, the Fujimori government had mass sterilization of women without their consent. And it was with this vision of, we know better, we know we need to control. It was the policies, like, I mean, like, it was the agreement, like the Cairo agenda, that allow us to move to a place where we put reproductive rights in the center. But I think that right now the reproductive rights and reproductive justice movement, it's under attack from the traditional voices, the conservative voices, the Catholic Church, the anti-choice movement. But also there are all these voices trying to go back to say, maybe we do need to control population. Maybe women do know, I mean, they don't know better, and we need, and those policies are always targeting the most vulnerable population. They are not saying the wealthy people needs to stop having kids. They're saying the indigenous people need to stop having kids, the people with HIV, the African descendant people. So I think that we need to be mindful of those voices, because with the environment agenda being more prominent, and I think that it has to be more prominent, this is kind of like the wrong door, kind of like a false door of saying, oh, if we do this, we're going to solve also the problem of environment. So I think that what can we do? I think that there are like different, like, we need a systematic approach. This is not, there is no silver bullet. I mean, like, we need comprehensive and systematic approaches for this issue. We need to check ourselves. We need to check our own prejudices on everything that we do, and we need to defend and maintain the reproductive rights and the reproductive justice agenda, because it is under attack for a lot of fronts.
And I thank you for sharing that. And I just wanted to follow up briefly before we move on to the next question. You had mentioned the kind of, the people who were the people who might have been the hospital staff in that case that I brought up in North Carolina, who might have been illegally and without consent searching, giving urine checks, and then coordinating with the police to arrest pregnant women who recently gave birth. I don't think they had good intentions. And I think of this quote that says, and I think this is what we need to be mindful of when we're developing our movements, right? There's a quote that says the road to hell is paved with good intentions. I think the road to reproductive violence and coercion is paved with good intentions, right? We can always say, okay, for the purpose of the fetus. We also know for the last few decades and years, we also know that many of the laws have been directly violating pregnant and birthing folks' rights in the name of protection of the fetus, right? And so I think there are various ways in which the legal intersects and undermines the sort of human rights approaches when we're thinking about birth, when we're thinking about beyond instances of birth, right? When we're thinking about, we just need to be mindful of the way these systems intersect to violently harm people, and good intentions can be framed in multiple different ways. It doesn't make it any less violent.
Absolutely, and I like that. That was exactly my point. That sometimes when we look, and when we're trying to find the kind of like worst policies, we think that like we're gonna find like these evil people, and it's not necessarily that. And sometimes it is our movement. It's like sometimes the intersection. So that's why I said like we need to check ourselves all the time, because sometimes we could, with good intentions to advance the agenda in one side, we may have the same prejudices against specific populations that are many times invisible.
Thank you.
Great. I appreciate both of you being able to touch on that so eloquently. How has the global gag rule exacerbated the unique health disparities that affect minority populations in Guatemala and Honduras? And what is the legacy of previous versions of the global gag rule in Mexico, Jamaica, and other countries of Latin America that previously received U.S. family planning aid?
So one of the things that I'll say for those, I think this audience knows what the global gag rule is, but I'll just briefly mention that it does prevent foreign NGOs from using U.S. aid or non-U.S. funds to provide so it prevents NGOs from using their own non-U.S. funds to provide abortion services, information, counseling, referrals on our advocacy, and sort of like rather than serving public health, this policy, as we've seen in various ways, and I'll get into, really curtails access to these essential clinical services and strips healthcare providers, as well as local organizations, community advocates, of the ability to engage openly with patients, with clients, with everyday people who are in need of these services. And I think before understanding what the legacy of previous versions of the global gag rule means in the context of Jamaica, that used to have previously received U.S. family planning aid, it might be helpful to have an example of kind of what kind of work was done on the ground. So for example, with the organization that I have worked alongside, E4Life, which is an HIV/AIDS organization for young women, as well for positive women and their children, as well as for women who have survived, for survivors of sexual violence. So they have an initiative called the Mentor Mom Initiative, and it embraces a circular model of care and support that is based on the work of staff and participants who are mentor moms, educators of HIV, sexual and reproductive health, and mentee moms who are newly diagnosed women and students in training. And the reason why this model was so critical is that it really moved beyond that sort of individualized care and shifted to holistic care, understanding how people are situated within structural conditions that expose them to vulnerability and that heighten their premature death. And so when this organization came in and entered the space, what it did was provide one, a way to amplify the needs of women in this national and sort of regional space of HIV/AIDS activism, and to tailor interventions that are directly addressing their unique needs, right? Offering these services. And again, integrating service delivery and provision with advocacy and training. And so it's called the Mentor Mom Initiative, and it remains a paramount, and not just organization, but I would say in the country of Jamaica's entire HIV/AIDS response, to the point where the government had adopted it to serve as a model in the public health system, right? And the point of it is to really address the particular needs of teenage mothers and young adult women living with HIV, and really finding ways to develop a relationship with these communities amidst the decline in funding streams for HIV/AIDS care and reproductive health, right? So there's a whole backdrop occurring in the context of this, where the work that's invested in women's reproductive health is being divested from, as you know, via the global gag rule and others, where just access to funding streams is just not there. And so this organization used to focus on, well, it still does focus on providing direct services such as trauma counseling, orphan care, care packages for canned food, feeding people, right? Because in order to take the ARV medicine, you need to have food. If you're living in cycles of intergenerational poverty without any sort of source of any kind of income, it's hard to take the medication if you're on a hungry stomach, right? So they provide baby formula, hygienic products, but they also function as a broader social movement through a feminist mobilization around sexual health, reproductive justice, and gender equality. Bam. So this is a phenomenal program. It's doing meaningful work. Again, it's E4Life, Google it. When the global gag rule happened, what that meant was the funding streams dwindled. And what happened was people started focusing, I would say a lot of funders and donors started focusing on how do we measure and evaluate success? And often when you have programs like this that focus on the holistic development and the holistic care of individuals and particularly marginalized groups, they sometimes operate on a smaller scale that I guess is not sexy for donors. So what that means then is the metrics of evaluation of these donors, these UN organizations and these donor funds who have been instrumental in supporting the infrastructure to carry out these kind of service provision and advocacies for reproductive health services on a broad scale. What happens when they're divested from is that you have little resources to be able to carry out this work. And what you have is not just people competing for little resources, but you also have people on the ground who used to receive care to save their lives, who used to be embedded in structures of communities who were being funded. Now they have to think about how they might carry out this work with no pay, while you have care labor, while you have mouths to feed, while you have also aspirations for continuing your career, for developing your career, for sort of traveling, for you have a life of your own that you also want to sort of advance, but you can't, or you also want to support, but you can't necessarily do that because the organization you were working with is perhaps not funded in the way that it used to. So I think the direct impact has been communities have had to find ways to survive and make a way when there is no way. And I think that's what's always been the case. So I think it's not a huge surprise that these kinds of important investments were disrupted via policies like the Gag Rule, but it doesn't make it any less devastating on the concrete impacts of communities that have continued to find a way and make a way out of no way.
Yeah, and I think that's the drama of the policies like the Global Gag Rule, that at the end, the most affected, they think that they are affecting, I mean, they have a political intention to affect the movement, to affect, like in this case, the sexual and reproductive health and rights movement and the abortion movement in specific. But at the end, who pays the price for this political scam is those women, men, young people who need the services, and they suddenly cannot access it because the organization are like face this dilemma. And this is a difficult dilemma for an organization like Jallicia was explaining. You have these great programs that depend on USAID money, and then suddenly they have to decide, okay, and I like in the case of like, for example, Guatemala or Honduras, that and several countries that are still like, and this is very interesting because before Trump, the Global Gag Rule with the Bush administration or with the Reagan administration, the Global Gag Rule only applied to the kind of like to the bag of money that was the population money from State Department, USAID. So what you had was organizations working on sexual and reproductive health, making that decision. And many organizations had like, I mean, suddenly you have clinics and you provide your organization that provide clinical services, and you provide sexual and reproductive health, but also other services, malaria, other services. And suddenly you are facing this dilemma when it's like, okay, I know that in some cases I need to give my my patients support on abortion, give them information, talk about maybe unsafe abortion, and I won't be able to do that. And I know that is my responsibility as a service provider to provide the best information. So if one of my patient is facing an ectopic pregnancy, and I know she could die from this pregnancy, and actually in this country it's legal to provide an abortion for a medical emergency, or like in a case of an ectopic pregnancy, but you cannot talk about that. Or you know that this pregnancy, it's like you have a 10-year-old coming to your services, be pregnant for evidently for due to a rape, having to face that dilemma, like if I want to keep open my clinics, I need, and that's why it's a gag. Like I need to gag myself, and I will have to live with the moral dilemma of not serving the people that I need to serve, because I cannot, it's not about only giving services, abortion services, giving them information. It's like like anything. So you know that you cannot provide the service with your own money, and I mean not US money, but your own money. You cannot give this 10-year-old the information she needs, even if it's legal, or this woman who's facing an ectopic pregnancy, just like you have to go to another service. And in many communities, there are no other services. So organizations are facing this dilemma between, when the global gag rule was inserted, like, should I keep my services open because all this population need my service? And again, here we're talking about the most vulnerable populations, because the population that are served by NGOs are the most vulnerable population. The rest of the population may go to private clinics or even government services, but these are the most vulnerable population, that maybe there is one clinic in the entire community. And that doctor is like, should I keep my clinic open and follow the global gag rule and not give out the information? Or should I keep giving this community a comprehensive service, but knowing that maybe I will be open only for a couple of months because I'm gonna lose all my. So it's cruel. It's a very cruel policy that at the end affects the most vulnerable population. It's completely inefficient because it doesn't. I mean, if the aim, I mean, it's efficient because it's a political tactic, but if the aim is to reduce the number of abortions, it's completely inefficient. It doesn't reduce. There is no proof that the global gag rule reduce the number of abortions. No proof. This question has been asked in the Congress. Nothing that these reduce. What it makes it like more dangerous for women. So it's not effective at all. What it is effective to reduce abortion is family planning or access to contraceptives, comprehensive sexuality education, and addressing sexual violence. That will, like that combo, access to contraceptives, comprehensive sexuality education, and addressing sexual violence, those are the type of policies that the anti-choice movement should be championing, because that's what reduces the need for an abortion. It won't eliminate the need for an abortion, but it will reduce it. So I want to see the anti-choice movement championing the policies that actually works to reduce, if they really care about abortion. But we know their agenda is about women's body control and not necessarily the abortion. So the effect of the global gag rule was huge. The old gag rule, the Trump gag rule, that it was a gag rule on asteroids, because it expanded its reach from the population lack of money to all the USAID. So what Jallicia was saying, suddenly the HIV movement was affected by the global gag rule. We had a couple of cases, for example, of organizations in Colombia working with migrants from Venezuela, working on humanitarian crisis, where they were put in this dilemma. Okay, we have all these women from Venezuela coming to Colombia looking for an abortion because they were raped, or because they're facing these pregnancies that they cannot afford right now. And abortion is legal in Colombia, but they were not able to give them these services because suddenly, if they needed the money, like, I mean, if they suddenly gave it these services, they couldn't take the money from the US. So they were in this dilemma. Should we keep open the work what we do in humanitarian settings, or we give women all the rights and the choices that we need? So this global gag rule, the Trump global gag rule, was even crueler than the previous one. And that's why it's fundamental that we stop this game between the Democrats and the Republicans about imposing the gag rule, like remove it, and then imposing. This is the time to remove it once for all, because at the end, who are suffering from this evil game are women, and the most vulnerable women in the field.
Amen. Absolutely. Thank you so much, both Maria and Jallicia. I'm going to kick it over to Lindsay to speak on some of the actions that you all can take to make an impact.
Thanks so much, Giovanna. And I want to thank again Maria and Jallicia for that really incredible discussion on inequities and access to reproductive healthcare for the communities that you serve and that you research. You know, some of you have joined us for national volunteer calls before, and if this is your first one, we don't have a national volunteer call without giving you ways that you can now take action to expand access to comprehensive reproductive health care for people all around the world. So, you know, you just heard a lot about the Global Gag Rule and how this policy impacts people all across the world and the really devastating chokehold that it's caused on aid to provide really essential services. And as many of you know, we've been working really hard for the past 4 years to pass the Global HER Act, and we are closer now than we've ever been before. So Lauren is going to drop a link in the chat where you can call and email your senators and representatives asking them to support the Global HER Act. And I can already see some of you, you've joined this call before, you're like, I've already done this once, maybe twice, maybe 5 times, but it's really important that you do it again. We are so close to getting this policy passed, and these next few months really are gonna make the difference. We've gotta get this passed this year to ensure that no future president can reinstate it. So if you've already done it once or twice or 20 times, I'm gonna ask you to do it again to help keep up that pressure and make sure that this is on the top of their mind. So go ahead and click that link, call again, email your senators. We're running a little low on time, but I'm gonna hope that you all, after this call, take that time to give your senators and representatives a call. It's past 5 on the East Coast, so you're gonna hit an answering machine anyway, so you won't even have to talk to a real person. It'll be really great. I also am super excited to announce our 3rd annual Summer of Her program. So Summer of Her is an 8-week field project of the Fight for Her campaign, which will run from June 7th through July 31st. We're recruiting Summer of Her fellows from across the country, across different experiences, who will come together and learn crucial advocacy and organizing skills to repeal the Global Gag Rule. Fellows will attend one skills training course on an advocacy or outreach skill each week, complete 3 hours of field practicum, and then have access to bi-weekly leadership development and networking opportunities. So the typical time commitment for this program is about 5 to 7 volunteer hours per week. And it's completely free, which is the best part. So Lauren's gonna drop a link in the chat to the application where you can apply. Fellows are accepted on a rolling basis, so make sure you apply early, and the deadline to apply will be May 16th. Also, if you're interested in learning more about the fellowship or you have questions, I'm dropping my email in the chat. Feel free to reach out and email me. All right, and then our 3rd and final ask. This month is National Minority Health Month, and we cannot talk about that without addressing the Black maternal health crisis that's happening in the United States, where Black women are 3 to 4 times more likely to die during childbirth than their white counterparts. Congressional leaders led by Congresswoman Lauren Underwood, Congresswoman Alma Adams, and Senator Cory Booker have introduced the Black Maternal Health Momnibus Act to address this crisis. So we really support this bill, and we want to make sure that it gets passed. And we want to also raise a little more awareness about this on social media. So Lauren's going to drop a link in the chat where you can easily, with just one click, tweet at your senators and representatives to call out the importance of this legislation and ask them to support it. So I did a whirlwind of the 3 actions in just 5 minutes. If anybody has any questions, drop them in the chat and we'll be sticking around. But I'm gonna kick it back to Giovanna.
Thank you, Lindsay, and thank you to everyone who has joined us tonight. Thank you, Jallicia and Maria, for this riveting conversation. I really appreciate you showing up and speaking honestly and earnestly about what's going on and what we need to do. And again, want to encourage you to make those phone calls, send those emails, tweet, and apply for Summer of Her. That's what I'm most excited about this summer. Don't do me dirty. Don't leave me hanging. go ahead and apply and come join us. And thank you all so much. Have a wonderful evening.